Everybody. Welcome to the Consultant Forum this evening. Thank you for those joining us in real time, and this will subsequently be circulated to those who can't. It's a great pleasure to welcome a team of presenters this evening regarding invention and entrepreneurship, and I'm going to leave the floor to Miles Parks to set the scene, and we'll get straight into the talks and hopefully plenty of time for discussion at the end. So Miles, over to you.
Thanks, Justin, for providing the opportunity for this session. We want this to be very much interactive and for people to share their experiences. Motivation really for putting this on, firstly, comes from the Biomedical Research Centre, which does have as one of its core aims sort of fostering interactions with industry and promoting the health economy. And that's an important goal for us, particularly here in Cambridge, where of course we're surrounded by endeavour and smart people and so on and so forth. But as well, recognising that we've got a wealth of consultants who have themselves engaged in this space. I think this originally came from a walking trip that I did with Patrick Axon, who I'm hoping is going to join us as well. Patrick, I was a bit taken aback to hear that he had invented something which is now widely used in endoscopy in our field, in gastroenterology. Good for him. But hearing the adventures that he had getting his product through to commercialization really struck home to me that this is not necessarily an easy journey, and that for people who are setting out on this journey, probably lots to learn from colleagues, and as well knowing that from other conversations with other colleagues that actually the support mechanisms that we've got in place aren't necessarily always what people feel that they want or feel that they need, and that maybe some sort of slightly looser and more informal support network and peer network could be helpful to us. Nonetheless, as we began on this sort of journey from the BRC perspective, recognizing that we've got a good office that deals with this, the Office for Translational Research, which is funded by the BRC, I then found Daphne Kiravino, who's going to talk to us in a minute, and Terry Parlett, who's going to talk as well. And amid the myriad different routes that you can go to get support for your ideas and for commercialization and grant support and so on and so forth, we came up with this idea of, if you've got a question about commercialization, we simplified it to call Daphne, because I figured we needed a simple route that people could remember. And so at some point, Daphne, if you wouldn't mind just sharing your contact details as to, I don't think it necessarily is Daphne's direct email, but it's a concept that Daphne will be able to signpost to you what's the most appropriate route through the often quite confusing network of potential routes that you might come in. So at this point, I'm going to hand over to Daphne to help walk us through what support is available through her mechanisms with Terry. And we've then got a series of speakers who are going to give us a quick fire view of their own experiences before we then throw this open to the audience and hear from you as to what your experiences and lessons learned. And we may end up at the end of this deciding that the next meeting should be, in a bar or a pub or somewhere a bit more relaxed over lunchtime, a sandwich or what have you, so that we get a chance for a proper chat together. So Daphne, over to you. Thank you very much, everybody.
Thank you, Miles, and thank you, Justin, for inviting us to speak today. So as Miles, sorry, I'm just trying to change my slides. Okay, so as Miles has introduced, so then we are going to give you an overview of commercialization of innovation in the academic world, and then we are going to also hear from the BRC device and advanced therapy team, and then hearing from colleagues and their journey into introducing innovation into the market. So this next part, I will start. As Miles has mentioned, I'm Daphne Kiravino. I am the BRC IP manager. I sit at the hospital in the R&D department, and will be followed then in the presentation by Terry Parlett, commercialization director in Cambridge Enterprise. So why do we talk about commercialization? we are a hospital, and I always like to go back to the vision of the hospital and the trust. So it's to improve the people quality and life through innovative and sustainable healthcare. And actually commercializing intellectual property can be a vehicle to actually achieve this vision. And by doing so, positively really influence the service and treatment in the NHS. This is by, for example, disseminating a knowledge of, to an audience larger than the academic community, giving the healthcare system new products, medicine, diagnostics, in order again to help patient benefit and also engage with industry partners and attract investment that will help again push forward the innovation. And and why we do so? Because some of the innovation, especially in the healthcare, cannot be realized in full at the academic level. We need a certain point industry to step in. So we talked about intellectual property. And so what it is, and I think the take-home message of today's talk is that IP is not only patents. Actually, during your employment and your work, you do generate a lot of IP. There are different type of IP rights, and these are rights that protects the creation of the mind. So some of these IP rights are non-registrable. It means that you don't need to apply in order to be protected. And examples of these non-registrable rights is a copyright. During, again, your work, you might, for example, write a manual to train some healthcare staff, or you can develop some new software code. All of these written material is protected by copyright. Another right is database rights. And this could be, for example, a database of clinical data that is curated in order to train a machine learning algorithm. Then we do have patents that are registrable rights. You need to proactively apply in order then to have protection. Patents protects inventions, so it can be a new medicine, a new diagnostic method, or a new medical device. And in order to get protection, you need to prove that your invention is new. It is inventive, which means that it provides a solution or an answer to a problem that is not obvious based on the current knowledge, and also it needs to, of course, to have some industrial application. Then there are a set of rights, IP rights, that can be both registrable and non-registrable. The first one is design rights. In healthcare, we don't often use these rights. They do protect the shape of, for example, of something. So how an object appears. It can be the shape, for example, of the Coca-Cola bottle. And then we have trademarks that do protect logos or name of products. And actually, tonight you will hear two examples of devices that have been developed in Cambridge that have been also protected with trademark rights. So the Cytosponge and CamProbe, for example. So now you know what type of IP you develop, and nonetheless, I think you don't need to remember all these details, because if you're unsure what type of IP you develop and how to proceed next, actually there is a large team of people again that can help you with these questions. So every month we do run monthly drop-in sessions open to any NHS staff and the university staff that have questions about commercialization and intellectual property. And the next one is on the 8th of March, but you are again welcome to accommodate to tell us when you are available, and then we will accommodate any date. And our friendly chat of 20 minutes, and they are bespoke. So we answer your questions. So any type of questions about any type of idea you have, then we will give you advices on how to proceed next. So I'm using we because, again, the trust is supported by a large team. So first of all, there is me. I'm sitting again at the R&D department of the trust, and I deal with any query related to IP and commercialization. And if the IP is generated by collaborations between the university and the hospital, then IP is supported by Cambridge Enterprise, that is the technology transfer office of the university. If IP is generated by CUH employees only, then this is supported by Health Tech Enterprise, that it's another technology transfer office. Again, as before, do you need to remember all of this? No, as Miles has said, just contact me or contact again at the email address that you see. I'm probably the only person at the trust that has intellectual property in its job title, so I think I'm easy to find.
Daphne, can I ask you, would you automatically steer people to either Cambridge Enterprise or Health Tech Enterprise, or are there other options that you might choose to steer people towards if it was something else that was more appropriate?
Well, these are the two main, again, supporting routes. Then it's always again a discussion. I think one thing that you need to start with it's a little bit of due diligence about the intellectual property, who owns and everything. And these two organizations are really well equipped to help you going through this. And at the same time, again, it's also receiving advice from experts that license intellectual property every day, so they will be able to assess the commercialization.
Sorry to interrupt. We better move on because time is much.
Yes.
Thank you.
So then I am again. There is a Terry Parlett here with me, and so he will go through how Cambridge Enterprise can help.
Brilliant. Thanks very much, Daphne. So now we know what IP is, and we know that it arises during our work quite frequently. And in fact, any innovation will probably have some form of IP that can be protected within it. But what I want to take you through, having spent, before coming to Cambridge Enterprise, 14 years in the health service, commercializing technologies, innovations, anything from software, imaging technologies, diagnostics, spinning out companies, all sorts of things. It's all applicable here to the commercialization journey that we're going to discuss. Just to give you a brief overview before I go through sort of more of a generalized view of commercialization from a tech transfer point of view, I'll quickly mention what Cambridge Enterprise does. As Daphne says, when there's university and NHS staff involved, we are here with our services. We can provide consultancy services, so take care of all those insurances, contracts and pricing, for example. When you want to transfer your knowledge to an outside organization, be it industry, governments or other institutions. We also have a research tools division. And this is where an innovation could be a piece of software, could be an antibody, could be a cell line or something like that is ready to go. And it can be licensed directly. And the Cambridge Enterprise will license that out directly to those organisations, again, with the team members involved to help us in that entire exercise. But what I'm probably going to focus on today is tech transfer and spin out side. So let's look at a commercialisation journey and also think about how we might form companies or actually just go straight to licensing. So Daphne, next slide, please. So this looks very simple, doesn't it? It's not in any way, of course. It's not really a linear process either. It's generally a revolving wheel of iterations that gradually rolls forward to an endpoint. And we'll get onto those endpoints in just a moment. But it begins with an idea or a discovery. And people would disclose that to us. We will perform an analysis and indeed protect the IP, as Daphne had talked about earlier, but let's just sort of break into the analysis a little bit more and see what's under there. So, we've simplified this obviously heavily, but, what is the problem, first of all, and actually what is the solution? What is being solved? What are the novel features and the applications of these novel features? Actually, does it have other customers outside of what we think? Is there vertical or horizontal customers we can get to too? And indeed, what's the market size within those segments? And how are we going to take it to market? What's the route to market for these technologies? There's other aspects, of course, who are the competitors are out there? How does our solution perform against the competitors? Is it better, faster, cheaper, all three? Let's know those companies that are out there. Where are they located? Who are they selling to? What are their activities, size and strengths? And where are they going in terms of products? And we've got to build that attractive commercial opportunity around it. So we need feedback sometimes, actually from the community, from potentially a licensee that we want to license the technology to, but are there any barriers to adoption we haven't perceived? What's the feedback from a current industrial partner? How does it fit in the current workflow? Particularly important for NHS innovations. How does it fit in that workflow? Does it disrupt something else somewhere else? What are those customer requirements that we need? And indeed, just build relationships anyway with those potential licensees. So obviously, we've got to then develop that solution further, and it needs to go through a development. It needs performance data. It needs to maybe a prototype developed. Maybe it needs to be tested industrially. Maybe it needs to have preclinical testing or indeed a clinical trial to get it to a point where it's attractive to industry. And where are we going to get that funding from? Is it proof of concept funds of ours? Is it funding provided by OTR or CATS perhaps, or indeed going out for other funders? And of course, thinking about the team and the strategy, and we'll come on to that a little bit more, I think, when we get to the spin out slide. But essentially, do we have the right team here to sort of back up the innovation, or do we need to bring in some other experts? And Daphne, if you sort of click the next slide through, we help convene some of those people. So some of those experts we will have in residence. Some of those people will have as mentors and consultants on our books. Otherwise, we'll go out with a sniper rifle, if you like, and find them. But it could be market research, regulatory experts to look at some of those regulatory hurdles that might be a barrier to adoption, find those fundings, like I say, using colleagues at the Office for Translational Research and ANITA, and indeed CATS and others around the ecosystem, or indeed find some design houses and prototype companies, get maybe research governance involved. Maybe there's lots of data and we've got GDPR conditions to look at, or consent matters, or indeed looking at research contracts where they could be reached through from industry over your rights. And we've got to make sure that those rights are free and be able to be used. Daphne, next slide. So then ultimately, what do we get to? Well, generally, we've got a couple of outputs. Often it's a license or a spin-out company. Now, when we're obviously thinking about sort of forming a company, I'll come on to that in just a second, that goes down a slightly different route to technology licensing. But if we try and compare them, licensing is often when we have an existing solution that has a niche. It's not a platform technology with lots of different opportunities, but it generally fits into quite a niche, but leverages the existing team and the marketing and sales expertise of the company with our technology. It's usually a product that's an incremental or an improvement to what already exists, and the financial return is linked to the success of the product. So we get royalties basically when things are sold. Whereas a spin-out company is where we need to build a new team and infrastructure because there isn't an existing ideal company to take up the technology, or actually where the technology is a platform technology or is a pipeline of products, if you like, or disruptive technology that will make a really good company and hopefully, form the next unicorn for Cambridge, as it were. Or indeed, do we just go back and rethink, put on our thinking caps and think about the strategy a little bit more? But ultimately, that's where we'll end up, a licensing or spin-out opportunity. And indeed, we will license to our own spin-outs as well. In terms of the spinning out, of course, lots of this is about the founder's vision. Where is it going? And the person that's really going to sort of have the ideas that's going to push this this company forward. But do they have all the skills as well? Might not be having the skills of finance or indeed marketing or sales, and maybe they need to be brought into the team. And actually, what is the business plan that sits behind this? You know, how can we help with that and indeed build up a business plan that will sit in front of investors and look attractive so that investors will ultimately put their hands in their pockets and part with their cash? What's the value in the business? You know, is it patents? Is it copyright? Maybe if it's software, or is it know-how and trade secrets? But we've got to make sure that chain to IP is clear so that the company has freedom to operate in its technology area. We might have to go out fundraising. Of course we will. If it's a new company, we need to talk to investors. But what's the amount of investment we need? What's the value of the company at this really early stage? How do we get that investment if it's not from venture capitalists? It might be from convertible loan notes from some angel investors around Cambridge. In terms of the product or service, you know, is it going to need those regulatory hurdles to be gotten through via clinical trials? Or indeed legals. So we obviously help out with all the documentation, your articles of association, the shareholders agreements, you know, what's the share structure, what kind of shares does an investor want? All these things that we need to consider and indeed help advise the team on. And certainly sort of to come back to the point about the team, it's such an important thing, is getting that team and that fit right. And I'm pleased to say actually in Cambridge and the network that we've got here is extremely helpful in order to provide the support that's needed. Daphne, next slide. So the seed funds team, and I'll quickly run through this because I know time is of essence, but they can provide up to 20k just in terms of sort of finding out as a pathfinder to finding out a little bit more about the market, perhaps maybe developing a little bit more on the prototype or indeed just taking the project along a little further. If it needs more cash, then we've got a Fast 75, which is a convertible loan note. So whereas the Pathfinder is a sort of a small loan, the Fast 75 obviously is larger, and we often match that with other investors. But it's further validation of the opportunity, possibly further experiments, possibly further development of the business plan. And then we can place equity investments up to 500k generally in the first tranche of funding that we will put into a company, but up to $1 million plus. And certainly now we're getting into the business of following our investments through into Series A at least as well. And of course, we've got Cambridge Innovation Capital, our partner that was set up by the university, which is there to do those big chunky checks, such as your kind of your 10 million, 20 millions, etc., to follow the funding for those spin outs that we create. Next slide, please, Daphne. And just to finish off, talking about those mentors, those consultants, those people that help us, we have the Cambridge ecosystem. Now, I am not going to go through this slide because it would take about an hour. Yeah, good. Everyone says good. But the point is, I think the role of us here is to convene and help introduce people to the various aspects of the ecosystem that can help in that commercialization journey. And of course, we do have those colleagues here from the Office for Translation Research and the Cambridge Academy of Therapeutic Sciences. But we have people here outside of that as well that can help in terms of space, that can help in terms of venture funding, that can help in terms of entrepreneurship, or maybe you've got a young student or a postdoc or a young clinician that wants to go on this journey and they can join some of these teams such as iTeams, QTech, EPOC, and these other things run out of the Maxwell Centre. But the point is, we can help in navigating that ecosystem. So in a nutshell, that's Cambridge Enterprise and a commercialization journey, albeit rather a generalized view. Whistle top store. Daphne, you might want to introduce the next presenter. Actually,
I'm going to seize the reins now, if that's okay. Terry,
brilliant.
Daphne,
Thanks, Miles.
thank you so much for that whistle stop tour, as you said. That was really helpful. Daphne, I know the chat's been disabled. Perhaps we can just enable the chat, whoever's in charge of the controls. And Daphne, if you wouldn't mind just putting your email contact on there, that would be great, just so that people know how to get hold of you and Terry. Even if they've got any questions, there is no question too daft. I ask all the daft questions, and then you can add on to them. So next up, we've got Rebecca Fitzgerald. At the point when in the BRC, I was making the case quite strongly that we needed to have a devices theme, and in fact, what's become devices and advanced therapy theme, and we were considering who could lead that. What better person than Rebecca? And she's going to very briefly describe her journey with Cytosponge. Rebecca, over to you.
Thanks a lot, Miles. I think it's terrific we're having this session because certainly I've been on that tortuous journey, Terry, that you showed on that slide, and I think anything we can do to help each other make this navigation easier would be terrific. Next slide. So I think, we'd all agree there's often a gulf between the discovery science we do and how we then get that into the clinic, be that a novel diagnostic or a therapy. And this is now very much, front and centre of the life sciences industrial strategy that really sets an ambition to improve patient access to new innovative treatments and technologies. So it's about getting our technologies out there, but also getting them to the patients. So this new theme, as Miles says, it's devices and advanced therapies. What is advanced therapies? That includes cell and gene therapy. And we know that these topics are particularly challenging to move from research into practice. Next slide. So when we were setting up this new theme, Debbie Vickers, who's co-leading it with me, she's in neurosciences, she did some work to try and understand from all of us out there what we think, she did a sort of questionnaire survey, are some of the main barriers and bottlenecks, so that we could really try and think what sort of support would be helpful to get us over those bottlenecks. So these are the kind of key 3 things that came out. So the first is, often the pathways are very long and arduous, as Terry mentioned. So how can we streamline that pathway, reduce the complexity and the time scale? People said often there was lack of bespoke support. What sort of support do I mean by that? Things like health economics. Who can help with the health economics? How do I find them? How do I get that funded? Statistics. Some of these clinical trials are rather different in their design to sort of standard trials we might be used to. And how do we get that clinical trial support? The third is around the interdisciplinary input, because often when you start really progressing from those small initial concept studies, you need to start thinking about the infrastructure for prototyping, manufacture and scale up. And of course, across the whole university, when we look across to engineering, for example, manufacturing, we do have absolutely fantastic skills out there. We just need to know how to access them. Next slide. So one of the things we've set up in this new theme is a sort of one-stop shop that would help us go from pump priming and startup right through to scale up and manufacture. And people can dip into any point, of this one-stop shop, any point in their journey for a new device or therapy. So what we'll aim to do is to provide a sort of infrastructure where you can tell us, it's a sort of drop-in clinic, you can tell us what you're doing, what your innovation is, and what kind of support or information might be useful. And then we'll try and connect you simply with those people that could help accelerate that progress. And that might be anything from the trial design through to the regulatory advice, health tech economics, etc., etc. So we're just getting this going, and we really hope that it will be helpful to you, and we'd love to have feedback and we can adapt it accordingly. Next slide. So who are we that are working on this theme? So this is the leadership team. It's very much a kind of team effort. So with myself, Debbie Vickers from Neurosciences and Manahal Bance, George Maliaris from engineering, a lot of expertise in bioelectronics and also about the manufacture and scale up. Raj Jenner, who we're going to hear from shortly on the AI and imaging side. Brian Huntley in hemato-oncology for cancer immunoeffector and CAR T cell therapy, and Andrew McCaskey, who I think I saw on the call, in orthopedics, advising on cell and regenerative therapy. So I think between us all, we've got some expertise and advice that we can offer. And then, of course, we'll leverage other expertise and bring them into the fold. We also have a patient public involvement champion. Can also help with advice there, because I think we'd all agree it's absolutely essential that patient acceptability measures are embedded into our trials, and that will ultimately lower the barriers for access to technology. Next slide. So here's a few of just a whistle, literally 30-second sort of timeline for some of the things that I've come across in developing Cytosponge, which many of you may have heard of. This story, I think the first thing to note is that the timeline on this slide goes back to 2002, which just goes to show how long it can take. But I hope, we can all make that a bit quicker and easier for each other. So keep advancing it. So Cytosponge is kind of interesting because it's both a device and in vitro lab assays that we developed in parallel. So this is an esophageal cell sampling device coupled with assays to diagnose early cancer of the esophagus. And of course, we also have to think about who the at-risk group is that we would give this technology to. To develop the evidence base, we performed a set of clinical trials, starting with BEST1, which was kind of proof of concept, then BEST2, which was a fairly large case control study. And at that point, we actually licensed out, if you slow down slightly, Daphne, we licensed out the technology to Medtronic, if you can see that on your slide. So that was back in 2014. And then we set about doing our large randomized trial, BEST3. And the punchline of that was that we improved the rate of early esophageal cancer detection 10 times compared to GP usual care. Next one. One of the other things we've been doing is working collaboratively. This is work with Florian Markowitz in the CRUK-CI to develop a deep learning classifier and really think about how we do the diagnostic lab assay part in a way that could be scaled up to a population type of approach for screening. And this led us to develop a spin-out company, Cited. So you can see that we ended up doing licensing and then later on a spin-out to really sort out all the lab testing. So that has been interesting to experience both of those. And this came around the time of COVID. NHS Scotland actually gave me a call and said endoscopies really being curtailed because of worries about aerosols and also issues about manpower and people being diverted to other activities during COVID. Do you think Cytosponge could help with the endoscopy bottleneck? So actually this was a bit of an opportunity for us, and because we'd just formed the spin-out company Cited, we were well positioned to actually roll this out as a diagnostic test, and we've delivered over 13,000 tests to the NHS since COVID started. That's in the diagnostic setting for patients with symptoms and undergoing monitoring. And next slide, and this is really relevant because we have got therapies to offer our patients. For this to be a nationwide screening technology, as opposed to being used in patients with symptoms, which is what we're doing now in the NHS, we would need a very large mortality endpoint trial to show that we not only diagnose more cases of Barrett's, but actually reduce mortality. So we've just been funded by CRUK and NIHR to do this massive BEST4 screening trial. We're going to be randomizing 120,000 patients. So the journey carries on, I'm afraid, beyond 2023 to see if we can prove a reduction in mortality. And this will need outcome out to 10 years. So you can see through this kind of long course that we've learned a lot about the devices and the assays, licensing and spin out. So we're not there yet, but I think we've made some progress, and it's certainly been very exciting. And I would love to share with any of you who think that some of these learnings could be helpful to see if we could make your course faster than ours has been. So, and we're still learning, you know, so we've had, what are the things, if I look back, that could have helped? So sometimes I, didn't quite know where to turn for advice. Who were those multidisciplinary experts? How did we navigate the regulatory landscape? We often did it the long way round. I think now with all the advice on the table, Daphne and Terry and so on, it could be a lot simpler. Health economic modelling, we didn't really have access to, and that's really important around the, as well as IP protection and licensing advice, and we certainly made some mistakes there. And we still continue to learn. Implementation research is really interesting. You learn a lot of things when you're implementing these technologies that you don't learn through your initial trials. What are the requirements for that NICE have ultimately? How do we get stakeholder engagement? Because all of us, as clinicians, speaking for myself, we tend to be rather conservative beasts, and you don't necessarily want to embrace the new technology. How do you get your test into a clinical pathway? And also something I'm learning recently that Raj may also speak about is the rather complex regulation around AI algorithms. So these are some things that we've learned along the way, and happy to share, and hope the BRC theme can also help on this journey for people. Thanks, Miles.
Thanks, Rebecca, for that whistle stop, and thank you for your leadership of the devices and advanced therapies theme as well. We're going to pick all this up in a conversation discussion at the end, if that's okay. On next to Vincent, who's going to talk to us just now about matters urological. Vincent, over to you.
Thank you very much, Miles, and it's kind of you all to invite me to talk about what really is a very simple device. So first of all, this was the problem we had back in the time that we were thinking about. I was thinking about this idea with the transrectal biopsies, which some of you may know from the urology medical school days was a procedure which was not only painful but undignified and prone to infections, putting the needle to the rectum. So at the time that we developed this, the only other alternative was a transperineal biopsy using a GA grid, which is the picture you see in the middle. And the question and challenge that I was interested in was, how do you get the best of the outpatient, simple, effective way of the transrectal, but the safer way of transperineal? And that was where the CamProbe idea came from. Now, the most remarkable thing is, at the time I was doing this, I wanted to do a prototype just to see if it would work. And it turns out that our engineering department at the top of the hospital was actually able to machine tool and build things for you. And the fantastic thing is, if you do that in the hospital, you don't have to go through the entire MHRA process to do it. So that's what we did. So we built about 10 of those devices you see me holding, and we did a prototype study, which was published, and that led on to the NIHR I4I grant we got to develop the CAMPROBE. Next slide, please, Daphne. Now, when I was planning this, I asked myself, where do I want to get to, and how would I convince myself to use this device? And it actually turns out there's a lot of things you got to think about. First of all, it's obviously your device. Does it work? We showed it could work. You got to train people how to use it. So we actually developed a training package and, in fact, a YouTube video. Then, of course, you got to do the clinical trial to show people, because the first thing clinicians do when anyone comes to them with a product, he says, well, what evidence? So we needed to do that. But the other really key aspect was the patients, because how would they cope with this? This is thought to be a painful procedure. Of course, we developed design concepts to get over that. So getting a really strong PPI group was key. But the other side was also the health economics. Prostate biopsies are cheap as chips. So if you're going to bring something into it, it's got to be cheap as chips, or as cheap as you can make it. And actually, interestingly, since the time we did the CAMPROBE, other devices have come on board with a huge price tag, which have actually profited until the CAMPROBE arrived, I may say so. And the other thing, really oddly, is actually raising clinical awareness. There's no point coming up with the most fantastic thing, but if people don't know about it, then they're not going to take advantage of it. So all these things are like an onion, I like to think, of a project, which takes you from the prototype right up to where you want to be. And thankfully, CAMPROBE has hit all of those marks. And in fact, just last year, because of COVID, we were delayed by a huge amount. We actually have now gone to commercialization and the NHS marketplace, and also published a multi-center trial. And that up there is the evolution of the silver device you see at the bottom. I will leave you with this slide because I know I only have 3 minutes, but this is all the steps we had to do. You can see it at your leisure. I'm pleased to say that although it was a simple device, I thought, it's actually been patented in the US, in the Europe, and in the UK because of certain design features we put in, which really came from a clinician's perspective. How could I do this, and what would make my life easier? We've got our CE and CA mark now, and like I said, it's about to be marketed and hopefully coming to a hospital in the region everywhere in time to come. Thank you.
Thanks, Vincent. As a member of the Y chromosome representative population here, I'm looking forward to less painful prostatic biopsy devices. So well done. Thank you for bringing that on stream. Next up, go on, Vincent. Okay, next up we've got Raj Jina, who's going to talk to us about AI and his experiences in oncology and AI. Thank you, Raj.
Thanks very much, Miles. I'll try and keep this brief. So just going to tell you about the AZARES project, which was something that has been in development for about 10 years. And we just finished last month, in fact, an NHS X AI award that was designed to take the project further to its next stage. Next slide, please. So just a very brief thing about the innovation. Sometimes the simplest ideas are the best. It's basically a cloud-based machine learning algorithm that can automatically annotate radiotherapy images to speed up the process of radiotherapy treatment planning. Like Rebecca's story, it has a long history. Started with a chat with colleagues in Microsoft in 2012. Didn't really get going until 2015 because the math of machine learning wasn't good enough to do what we wanted to do clinically. It's been plugged in here in Addenbrooke's since 2018, and it went open source so that the technology became much more democratizable in 2019. The following year, we had a landmark clinical evaluation that was published in JAMA, and then in 2021 was the start of our Stage 3 AI Award. Next slide, please. So you've heard Daphne and Terry allude to the pathway that's taken, and often you'll hear this term about the valley of death. And it represents this stage that technologies go through from concept that may be sort of in the university setting through to deployment, which tends to be in the sort of industry and commercial domain. And so our vision was quite bold. We wanted to build the first open source AI imaging device from within the NHS and deploy it within the NHS, essentially at cost. And so you can see basically that the project was very much designed at bridging this valley of death and taking an open source research code and turning it into a medical device just like any other AI powered medical device. If you look at the boxes in green, I think as a consultant body, we are particularly good at dealing with some of these uncertainties around the valley of death. And I think that's something I'd like you to hold on to when you're thinking through your own ideas. There's something unique to us about being able to hold a concept because we have that clinical line of sight. We have that detailed domain knowledge that can keep things going. Next slide, please. So the project, as I mentioned, finished last month. Are we there yet? Well, I think so. So basically what happened is that we did a detailed clinical evaluation to turn this into a medical device, much more detailed than anyone else. And in fact, that set the bar for the evaluations of all of these types of imaging-based AI technologies at NHS England, and was included in a nice medtech innovation briefing of AI technologies in radiotherapy. We've got a complete technical file for UKCA marking, and we've identified a legal manufacturer in order to license the technology. It happens to be a company based in Germany and Poland who actually do mixed reality for surgical planning. And again, this is interesting. Sometimes you don't know the exact scope of the application of your technology, but things that we do to process images to prepare radiotherapy, precision radiotherapy, can also have ready application for the planning of precision surgery. And final slide, please, from me. So what are the lessons I'd really like to share with you? I came across this term, an intrapreneur, and I think it's a wonderful term that describes us as CUH consultants. When I was with the AI Award, there were dozens of tech companies at the same stage of us, all banging at the door, trying to get their technology that they thought that was smart and AI powered into a hospital. But we're already in the hospital. We have the ability to disrupt and innovate from inside of the hospital. So do not lose sight of that. It's an amazingly powerful position to be in. We've heard a lot about good advice, and it's amazing. I just wish some of these resources were available to me just as recently as the start of the AI Award. And as I learned from Jonathan Gillard, a radiologist that some of you may remember, don't ask a question that you can't unask. This is particularly true of the MHRA. They're a very interesting body. They have discrete pockets of expertise and knowledge. And if you go down the rabbit hole with the wrong person with the wrong question, it can take a very long time to get yourself out. So instead, speak to colleagues like Daphne and Terry at Cambridge Enterprise who can de-risk your questions for you. And also, if you're dealing with digital or AI technologies, NICE and NHS England have the multi-agency advisory service. It is superb. It's a very low entry point. Even a non-expert can go and ask a question and be directed in the right direction. If you're dealing with digital and data-driven innovation, just remember, we always hear that data is the new oil. Now remember that that oil is not created without patience in the first place and expert consultants to generate the actual interventions, the imaging, the data from interfacing with those patients. So it's that collaboration, it's us with our patients that generates the high value data. And finally, as Vincent mentioned very clearly, understand your entry and exit points for the step that you're looking for support for. So for example, one of the things that we discovered in our AI award is that it's not easy for the hospital to act as legal manufacturer for a software device. So that's fine, and we learned that as part of our work. But it's very, very important to understand these are the points that you have to have met to come into this particular stage of the game, and this is the next step that you're aiming for, and hold on to those when the days are dark. Thanks very much.
Guys, thank you so much. Brilliant and concise and complicated, but beautifully encapsulated. Thank you for that. And next up, Kurosh, to round us off for the last 3-minute presentation. Then we're going to throw this open to the audience for your perspectives and questions, of course. Thank you, Kurosh.
Thank you very much. Next slide, please, Daphne. So the problem that we are addressing are bile duct disorders, intrahepatic or extrahepatic bile duct disorders. As you know, there are no curative treatments, and liver transplantation is currently the only available therapy. Next slide, please, Daphne. So together with Fotis Ampaziotis, who's also, as you know, one of the consultant hepatologists, and Ludwig Valier, we had discovered a strategy for taking epithelial cells, bile duct epithelial cells, and basically growing them indefinitely in organoid format without genetic manipulation, and create a unlimited source of cells that we knew had the right phenotype, the right gene expression, right enzymatic activity. Next slide, please. So what we were then able to do was to show through a series of programs, including animal models and using human livers that were perfused on machine perfusion, was that we were able to basically get these cells to engraft in human livers and function. Next slide, please. Generating bile as a proof of principle that these cells were functioning, but also changing the pH of bile. And these cells are cells in red on the image on the left show a cross-section of a bile duct that has been partly repaired by our cells. So we were starting basically with a potential novel cellular therapy for treatment of bile duct disorders. Next. So we were at a point to really transition this scientific discovery into a potentially commercializable product. So the first thing we did was we co-founded a company. The key here is to have the right co-founders as part of the team. Fotis and I, who are the main co-founders, of course, both academics. So we needed a team, and we engaged with Cambridge Enterprise early on to benefit from the business and commercial expertise that's available, including working with entrepreneurs in residence at Cambridge Enterprise, who are a fantastic resource. It was important to protect the idea through patents or know-how, as mentioned. Sometimes these patents are misunderstood. People think that this means that we are being defensive, but that's actually absolutely necessary, because otherwise nobody's going to invest hundreds of millions of pounds developing your technology. We would recommend exploring Innovate grants, for example, from Innovate UK, that we were successful in obtaining, which means that actually we're not subject to the sort of VC pressures at an early stage, and this allowed us to generate large animal experiments. Now, the other areas of expertise that we lacked were things like manufacturing of a cellular therapy. We worked with the cell and gene therapy catapult to do process diagnosis to understand whether our product was indeed practicable in terms of manufacture. And they also did market analysis for us. And independent market analysis here was really important because it allowed us to pick our target markets. So all of these inputs will go into the fundraising and development plan, and we are currently in discussion with various funders for the next stage of funding. Next slide, please. Essentially, what we are creating is a platform company that combines the cells with bioengineered scaffolds that allow us to treat either intrahepatic cholangiopathies or extrahepatic bile duct disorders. And again, we've had to create a platform for understanding the regulatory and manufacturing implications of these disparate cellular therapies. Next slide, please. Of course, all of this wouldn't have been possible without the organ donors and the families, but importantly, this just lists the number of people and groups that have contributed to this, and it's really important to benefit from the expertise and advice from all of those. Thank you.
Kourosh, thank you for whizzing us through that at pace. So we've got 10 minutes or so for questions now. Could I suggest that we keep the questions focused on innovation and commercialization rather than necessarily on the cool science that we've just heard described, if that's okay? And just while we're waiting for one or two questions or hands to go up, please do stick your hand up. I think we've got chat function here, so you're going to have to ask your questions out loud. We've heard mostly from university innovators and inventors here today, but I know that there's a good bunch of our NHS colleagues on this call who equally have done their own innovation. I can also see in the chat that Mark Slack has been quite busy on that. Mark, do you want to just raise anything here? Louise Allen, I think that's you on the thing as well. I'd be quite keen to hear your interaction with the OTR and one or two other perspectives. Maybe Patrick and Andrew Grace, Patrick Axon, Andrew Grace, you can chip in as well. First to Mark Slack, please.
Just thank you very much. Great evening. Quick question. I think Rebecca, not quick statement, Rebecca's got the best message. Good science first, money second. Do it well, get the data around it and so on. Health economics, implementation research is really important. And then, there's not one source of income. Multiple, and I think you've got to be a bit mature about that and work out who best serves your needs. But I still go back to Rebecca's message. Really good science translates to really good business.
Thanks, Mark, for that perspective. Louise, do you want to share any of your experiences briefly? Sorry to put you on the spot.
That's okay. I suppose as sort of a lone clinician, I've been fighting the battles for so many years, and I've made so many errors, which I could have saved myself a lot of time, I think, if I had a bit more knowledge to start with. One of the ones was going to this venture capitalist to to build my second prototype. He'd made a packet in double glaze, no, not solar panels. And I think he thought he was going to make millions out of this device to screen baby cataracts within a couple of years. And boy, he was a bit upset when 5 years later it hasn't happened. But yeah, I think there are lots of mistakes we made. But I think one of the things I've missed is actually a team. I mean, I don't know about the academics, but you do have a team, whereas for me, it was just me as a full-time clinician trying to push these things on, and that was difficult.
Have you found your interaction with the OTR helpful, Louise? Can you just share your thoughts there?
Just remind me, OTR.
The Office for Translational Research. Have you had much to do
obviously
with
you found it very useful.
All right. So
no,
I think
no. I have worked with Cambridge Enterprise, and there are just a couple of frustrating things, like signing a license takes a year. And it's the same with the trust, really. I've got this NIHR grant, it's 2 years to sign a contract with the collaborators. It's just everything is so prolonged, and you just
there are definitely frustrations out there, and one of the reasons for putting together the meeting today and suggesting that maybe the next one happens down the pub or wherever is just so that people can share some of this angst, because I think that would help on the one hand, and secondly, some people will have worked out how to navigate this more smoothly, and that's another important. Mark shaking his head. But maybe peer support and a shoulder to cry on. If that's all we can offer, then I think that would be a useful thing. Patrick, I know you had quite an interesting ride through with the commercialization aspects. Anything that you want to share?
Thanks, Miles. I just want to say everybody's product that's been described today is fantastic. Mine's a very basic product. It's a diagnostic tool that goes at the end of a colonoscope. I started in 2001. It's finished in 2021 when we sold to Olympus US. What I'd say, listening to everybody, is, and I agree with Louise, is that the teams that you create are incredibly important. I very quickly realised that I was not CEO material and needed somebody that could cover that area, or finance. My finance abilities were pretty poor. So quickly realised that, but also around design, trying to make something with no money is difficult, but there are contracts and ideas that can be generated to be able to create designs, taking people with you, letting them have some of the potential upside. The other thing I'd just like to quickly say is patents are so important. We got into massive patent battles, went to court, had to defend our patents, and fortunately won. But I can't emphasize how important it is to get a strong patent if it's certainly a device.
Thanks, Patrick. Vikas, you've got your hand up.
Yeah, I mean, it's a quick question actually to all those who've been successful. I was listening to Rebecca's talk and I was feeling frustrated with my own that journey of 3.5 years. But when I listen to yours, it's fairly sobering. The question to all of you is, OTR and Cambridge Enterprise have been very, very helpful for us. So we've incorporated, we've done our preliminary studies. When does one stop becoming an academic enterprise and become a commercial enterprise? Because we may need X amount of money to complete the product as it is to be implanted in the patient. That may probably require millions. The industry money is essential at this stage. The academic money is not going to solve that problem. So how do you counteract that? That's the stage we are at the moment. So any tips on that would be really helpful.
I'm going to ask Daphne and Terry to pick that up, because I know they have some expertise here, and I think as doctors and scientists, we don't always recognize the expertise that we have internally, actually, to tell us when is it a question of applying for a grant, when is it a question of going out there for venture capital, or whatever else it is. And these guys really have got that expertise. Daphne, over to you.
I see that Terry unmute himself, so I think he's ready with an answer.
Well, I may be down the Judge Business School talking about just this subject tomorrow night, by the way. But yes, when do you go out? I think when you've got a product where you've got proof of concept, and ideally perhaps a little bit more in terms of your preclinical data would be fantastic, because ultimately you've got to go out for investment. I know, Vikas, you will be soon, and I think that is the right time. The product is at the right stage. You've got those studies under your belt. Should you never keep going out for non-dilutive funding? Probably not. there's certainly a stage before, you know, getting that proof of concept data so that you can go out for investment is where you need to go for that non-dilutive funding, talking to the Office for Translational Research to help find those grants that will give you translational funding to take it to that next stage. But any company, and I still know some pretty big companies that still go out for non-dilutive and other translational funding sources. But if you want to accelerate the development of the product and your product is at the right stage that investors can see that this can be reach the next inflection point with their investment, i.e. the value of your company going up at that inflection point, then they will put the money in. And it is obviously at that point to try and get the level of investment right to take you to the next stage. But in terms of not going out for other funding, no, I don't think there's ever a point where you stop going out for non-dilutive funding. I think it's always an important part of the mix, and can even complement. Your investors will love it as well, by the way, because then that's more money that you can spend of theirs on other things.
Terry. Thank you very much indeed for that. We've got 3 minutes left. I do want to get a comment from Andrew Grace, and also then perhaps just finally from Ashley Shaw as well, just to hear the CUH perspective on this. And then just to remind everybody that for any of these questions relating to anything, call Daphne. Daphne, do you want to just put your, I don't know whether you can put your name in the chat or whether we can perhaps circulate that on email a bit later on to people.
It's there, Miles, already. It's in the chat.
Good. Sorry, I've missed that, but thank you for that. Andrew Grace first, please, and then Ashley just to round us off.
So, Miles, thanks for inviting me. So basically, I think, you know, case of need is very important. And I've been fortunate in the world of electrophysiology and arrhythmias. There really were lots of areas that we could exploit and go into. And the most high profile, of course, subcutaneous defibrillator, but also catheters for ablation and mapping technologies that they've all gone through to market. But they didn't come entirely from me. We basically did the execution. We did adapt them through the process. But now I've got to the stage and with a network and communication, mostly through West Coast support, to setting up our own organisation and company to develop new technologies. So that's where I am. But it's, I think, and also just going back to Rebecca, I mean, it just takes forever. So you just got to stick at it.
Keep plugging away. It's true for most things in the research world and the clinical world, and it turns out in the tech and entrepreneurial world as well. Ashley, do you want to just give us a few bon mots just to round us off from the CUH perspective, if that's okay, and then I'll hand back to Justin.
Yeah, thanks, Miles. I have to say this has been a fascinating session. I think the number of people that have turned up sort of shows the interest there is. I think Cambridge is one of the few places in the country that could actually deliver the number of inventions and ideas that have come from such a range of people that we've heard about tonight. Vast range of things that people will be facing these problems day in, day out, problems that we didn't know existed, and they've gone ahead, not just moaned about them and whinged and said, this is a problem. You hear about Patrick and Vincent and Rebecca and Louise, and there are many others who we haven't heard from, who've just gone out and invented something and plugged away and made mistakes. And I think it's fabulous that we've been able to respond as a sort of local ecosystem to be able to sort of really start to build that expertise. And it's, as people have said, it's not a one size fits all. That's why this is about, on anything new that comes through, it's going to be more learning, more understanding the product, understanding the market, because this is novel. There is no highway to get from idea to market in this. So I don't think there's an easy way forward, but credit to everyone who's spent the decade or so doing the things that they've been so passionate about. And I'm pleased that we're able to help, and long may it continue. But thank you very much. Fabulous evening.
Thanks, Ashley. I'm just going to thank our speakers and particularly thank Daphne for pulling this evening and the session together. Thank you, Daphne, for that. And thanks to everybody for contributing. Justin, I'm going to hand back to you now just to wrap this up. Thank you.
Thanks, Miles. Very little else to say other than to thank everybody for their contributions. I think what tonight has shown me is one of the joys of working in Cambridge is the expertise around us, and with all the struggles of day-to-day clinical work, which we all obviously continue to enjoy and do. These sorts of things are so important to keep us motivated, interested, and it's exactly why the Cambridge Biomedical Campus is what it is what it is. So thank everybody for their efforts. Certainly made me feel very old being in the laboratory in the old MRC cancer cell unit opposite Rebecca 20 years ago. So I certainly feel older than I felt at the start of the meeting, but such is life. Thanks to everybody. A brilliant session. I'll forward it around to those who couldn't make it, and keep up the good work. Cheers.
Thanks, everybody.
Thank you. Bye.
Thank you.